I've been thinking about how to start this video for a while, and the only honest way to start it is to say, I have sickle cell disease. I've had it my entire life. I've never publicized it. Not because I was ashamed, but because I've always wanted to be seen as the expert first, the patient second, the governance authority, not the cautionary tale. But this month is National Minority Health Month. And what I'm going through right now, the treatment I'm undergoing, the systems I'm navigating, the genetic data I'm handing over begrudgingly, the forms I'm signing to exchange my biological privacy for the chance at a cure is not separate from my work. This is my work made flesh. And today, I'm making two introductions. The first, I have sickle cell disease. I am currently undergoing Lyfgenia, FDA-approved gene therapy that has the potential to cure it. The treatment costs $3.1 million, and I'm documenting the entire process publicly. I'm calling the series Lyfgenia, a public record. The second, the research on health data bias that makes my situation and the situation of every Black patient navigating this healthcare system not just a personal story, but a structural one. In 2019, researchers published a study in the journal Science examining a healthcare algorithm in use at hospitals across the United States. The algorithm was designed to identify patients for enrollment in high-risk care management programs. The programs that provide additional support, nurse coordination, and resources to the sickest patients. What the researchers found was this. At equal levels of medical need, the algorithm consistently rated Black patients as less sick than white patients. The reason was how the algorithm measured need. It used healthcare cost as a proxy for health, assuming that patients who cost more to treat must be sicker. The problem: decades of systemic barriers to healthcare access meant Black patients with equal medical conditions had spent less on care, not because they were healthier, but because they had less access. The algorithm encoded that history of exclusion and called it an objective assessment of health. After correction, 50% more Black patients were identified as needing high-risk care. 50%. Those patients were there the whole time. The algorithm just couldn't see them. This is what I mean by the body the algorithm never saw. This is not a metaphor. It's a clinical finding with a published correction factor. There are millions of Black patients whose medical needs have been made invisible by AI systems built on data shaped by discrimination and then asked to be objective. For AI in healthcare, the implications compound at every level: triage, resource allocation, drug approval prioritization, treatment eligibility. When those tools were trained on data that systematically underrepresents Black and chronically ill patients, the bias doesn't stay in the training data, it moves into outcomes, into who gets treated, and ultimately into who survives. What does this look like from the inside? Lyfgenia is a one-time gene therapy for sickle cell disease, developed by Bluebird Bio, FDA approved December 2023. I am among some of the earlier patients to receive it. The treatment works by modifying my own stem cells, extracting them from my body, using gene editing technology to correct the mutation responsible for sickle cell disease, and reinfusing those corrected cells. If it works as intended, I will produce functional hemoglobin. The pain crises, the organ damage, the statistically shortened life expectancy that come with sickle cell disease, they become potentially history. The price of this potential is $3.1 million. My insurance approved it. I want to be very clear about that because I'm not telling this story to say this treatment is inaccessible to everyone. I'm telling it to say this: the gap between FDA approved and patient receives treatment is enormous. And it does not fall randomly. It tracks race, geography, insurance type, and hospital affiliation in ways that are entirely predictable. The treatment centers that administer Lyfgenia are specialized academic medical centers. They are concentrated in major urban hospitals with research infrastructure that most communities, and specifically most Black communities, do not have geographic or logistical access to. If you are a sickle cell sufferer or warrior, the population in the US is mainly African Americans and Black Americans. Because of the theft and enslavement of those on the African continent, where the malaria virus predominantly wreaked havoc, and you do not live near one of these centers, the access barriers are not just logistical. They are compounding: transportation, time off work, childcare, caregiver logistics, income loss during a treatment process that stretches over months. In the exact communities where sickle cell is most prevalent, these are real, concrete barriers that have nothing to do with medical eligibility. I have resources. I have support. I have the expertise to navigate complex systems and the platform to make noise when they fail me. Most patients don't. And that is why I'm documenting this publicly. I also want to tell you something about the consent forms. To receive this treatment, I signed documentation covering genetic data collection, sharing with research partners, and potential downstream uses of my biological material. I am an AI governance expert. I read every word. I flagged provisions I found problematic. I consulted with people I trust about what I was agreeing to, and I signed because I want to live. A system that requires you to trade your genetic privacy for access to a life-saving treatment is not offering you informed consent. It is offering you survival at a price. For Black patients with a documented history of having our bodies used as medical research material without benefit or real choice, the weight of that trade is not abstract. It is historical. It is present. And it is happening right now in the consent forms that every Lyfgenia patient signs. This is what the series is about. Not just my journey through gene therapy, the governance document that this journey produces. For organizations deploying AI in healthcare or health adjacent spaces, here is what National Minority Health Month requires of you. Examine your training data. Where did it come from? Which patient populations are over and underrepresented? What conditions, what demographics, what medical histories are absent? The bias I'm describing is not theoretical. It is present in accessible clinical outcomes data. Audit your algorithms for demographic performance gaps. Are your risk prediction tools performing equally across race, ethnicity, and chronic illness status? If you haven't measured this, you don't know, and not knowing is not a defense. Review your genetic data consent processes for the patients most affected by health AI bias. The populations most vulnerable to health data bias are the same populations with the most historical reason to distrust genetic data collection. Consent processes designed without that context are not neutral. At Include, this is the work, our work. We partner with healthcare organizations and health-adjacent AI companies to build governance frameworks that center the populations most affected by health data bias. They are not seen as edge cases, but as design requirements. The link to book a consultation is in the description. This is the beginning of a public record. I'll see you in the next episode with the curb cut effect and what designing for one, then extending to many means, and the governance argument for why designing for constraint is actually the highest form of design innovation. And I'll update you on both Building Me Back and Lyfgenia as we go. If you're navigating something similar, a chronic illness, a system that doesn't see you, a consent form you signed because you wanted to survive, you're not alone. Subscribe. I'll see you in the next episode.